I wait until 4. Hello everyone, this is Monika Benstetter in Amsterdam. It is my pleasure to welcome you to today's bi-weekly press briefing in which we want to update you on COVID-19 vaccines and treatments. We have with us today Dr. Marco Cavalieri, the Head of Biological Health Threats and Vaccine Strategy, Dr. Fergus Sweeney, the Head of our Task Force Clinical Trials and Manufacturing, and Dr. Georgi Genov, the Head of Pharmacovigilance. Dr. Cavalieri will kick off today's briefing with a short overview of recent developments. We will then open the floor to your questions. A few technical points before we start. Your microphone is presently muted, but we will unmute you when you take the floor to ask a question. Also, this briefing is broadcast live via YouTube and Europe by satellite. The footage is available free of charge to any media organization. And now, without any further ado, over to Dr. Cavalieri for a brief update.
Thank you very much, and thank you for joining us for today's press briefing. I'd like to start by updating you on where we are currently with third doses and booster doses, which is a very prominent topic, as you all are aware. Let me first anyway reiterate that as all the currently approved vaccines provide strong protection against COVID-19 hospitalization and death, from a public health perspective, the priority remains on making sure that as many people as possible are fully vaccinated. When it comes to additional doses of vaccines, the evidence is becoming clearer on the need to consider this option for people who may respond poorly to COVID-19 vaccination, such as immunocompromised individuals. People with severely weakened immune systems may need an additional dose as part of their primary vaccination series. Studies in immunocompromised people have been published showing that immunocompromised patients are not always responding to the vaccine, and that a third dose of a messenger RNA vaccine after a second one, at least 1 month after the second one, is able to increase the number of subjects that mount an immune response. Such data are currently under review for both Comirnaty and Spikevax by our scientific committee, the CHMP, which will consider by early October if any specific recommendation can be included in the product information. It is acknowledged and understood that Member States are already rolling out additional doses for these people in order to increase the protection that can be achieved in the vulnerable groups. Booster doses, we know, remain a significant topic and of great interest. Booster doses, just to remind everybody, are doses that are given to vaccinated people after they have completed their primary vaccination cycle in order to restore protection after it has waned over time. EMA, together with the ECDC, is constantly reviewing evidence from vaccination campaigns to assess if the level of protection offered by the vaccines need to be enhanced with a booster dose. The available data are showing that immunity against COVID-19 from initial vaccination wanes over time, and that protection from infection and symptomatic disease is decreasing in different parts of the world. While the majority of the current evidence supports the maintenance of high levels of protection against severe disease, we are also starting to see preliminary data that would suggest some reduction in protection from hospitalization in the elderly specifically. Some Member States, therefore, have decided to start giving booster doses to a selected group of people in order to proactively protect the most vulnerable in view of the upcoming winter season. As already stated, EMA fully recognizing the reasoning behind such decisions. As you all are aware, along with data in immunocompromised patients for both Comirnaty and Spikevax, EMA is also evaluating an application for the use of a booster dose for Comirnaty to be given at least 6 months after the second dose in people aged 16 years or older. The CHMP will assess the safety and immunogenicity of this vaccine when it is administered as a third dose and will eventually recommend whether updates to the product information are appropriate. The outcome of this evaluation is expected in early October unless supplementary information is needed, and we will be communicated from our perspective. I would also like to reiterate that the CHMP has brought to a formal conclusion the analysis of data on the risk of unusual blood clots linked to low level of blood platelets, the so-called thrombosis with thrombocytopenia syndrome, or TTS, and the consequences for the use of a second dose of Vaxzevria COVID-19 vaccine. The CHMP and our safety committee, the PRAC, have now analysed all the available evidence. Our overall assessment remains that TTS is a serious but extremely rare side effect associated with the vaccine and is included and described in the product information. It is therefore very important that we remain vigilant. However, we could not clearly identify particular risk factors that make TTS more likely. But what the current data have shown is that there is no increased risk with the second dose, and EMA's recommendation remains that the vaccine should continue to be given in 2 doses between 4 and 12 weeks apart. This particular review is now closed, but the safety monitoring of the vaccines is a continuing activity which EMA and the national competent authorities share for the safety of all Europeans and people worldwide. We have also received several queries on the approval of vaccines for children younger than 12 years old. To date, EMA has not received any application for such an extension of indication for a COVID-19 vaccine. We are, however, already in contact with companies who are currently preparing to submit relevant data that would support such an extension. A bit of a background on the process. For every marketing authorization that is sought for a COVID-19 vaccines in the EU, a Pediatric Investigational Plan, or PIP, needs to be agreed with the EMA Pediatric Committee. The plan details the clinical studies that are needed to generate evidence that a vaccine is safe and effective in all pediatric ages up to 18 years. Pediatric clinical trials that are generally structured in a way that a vaccine will be studied first in adolescents and then progressively down in children below 12 years of age, down to the youngest ages. As soon as there are enough data to show that the vaccine is safe and generates a good immune response in certain age group, developers can submit the data to the EMA for an extension of the marketing authorization to that age group. As an appropriate guide on timelines, we expect Pfizer to submit data on children aged between 5 and 11 years in early October, and data from Moderna should be received at the beginning of November. The evaluation process for both applications should take around 4 weeks, unless there are specific aspects that require more discussion on the data. In the meantime, we continue our work on rolling reviews for 5 other COVID-19 vaccines that we mentioned in our last briefing, and we remain confident that at least for some of them, we could progress these rolling reviews towards a possible outcome later on this year or at the beginning of 2022. Vaccination is the cornerstone of our response to COVID-19 and is essential for getting out of the pandemic. However, people are still getting ill from the disease, and the urgent need for treatment remains at the forefront of our activities. In this context, discussions with developers are ongoing to expand the portfolio of available therapeutic options for the prevention and treatment of COVID-19. 4 different antiviral monoclonal antibody products are under rolling review by the EMA, as we described last time. This medicine will be useful to treat mild COVID-19 to avoid disease progression, and in some cases may also be very helpful in order to prevent COVID-19 overall. They will also be important for use with people with compromised immune systems who are unable to produce enough antibodies with vaccination. The reviews of these compounds are progressing very well, and opinions from the CHMP may come, at least for few of them, by the end of October. In addition, extension of indication for free immunomodulatory agents that are already authorized for use in other indications are already currently under assessment. All are intended for use in hospitalized patients with COVID-19 on top of standard of care in order to improve cure and ultimately survival. In addition, there is an active pipeline of treatments under development, including, for example, antivirals in pill form that could be used by people at home to treat or prevent COVID. This is why we continue to support developers of vaccines and treatments, and why last week we extended our fee waiver on scientific advice for COVID-19 treatment and vaccines. I will stop here and hand back to our moderator for questions.
Thank you, Dr. Cavalieri, for this very comprehensive summary. Now, I open the floor to questions. If you would like to ask a question, please click on the reactions icon on the bottom of your WebEx window and select the raise hand icon. We will then automatically unmute you so that you can ask your question. As always, we ask you, when you ask a question, please turn on your camera if you can. So I see now a number of hands already, and we give the first question to Maria Psara from EFSIN in Greece. Maria, please, you have the floor.
Can you hear me? Can you see me, maybe?
Yes, Maria, we can hear you and we can see you.
Hello, and thanks for this briefing and for the floor. I have actually one question. Mr. Cavalieri said that very analytically, but I would like to know, the Commission and EMA had said that by the end of October we would have 3 approved medicines, and by the end of the year 5 new medicines. What is the state of play? Because you said about the procedure, but I didn't get it. How many medicines we are talking about till the end of the year? Thank you.
Thank you very much, Maria. Dr. Cavalieri will answer to this question.
Yeah, so indeed, I said there are 4 monoclonal antibodies with antiviral activity that are in the mature stage of assessment. So we expect that some of them could be approved by the end of October and the other most likely in November. And then we got these 3 immunomodulatory agents that are also under review. They will all be discussed in October, and we will see if for any of them it will be possible to conclude already now or whether we will need more time. But I would expect that at least for some of them it should be possible to conclude very soon and by the end of the year for sure.
Thanks, Dr. Cavalieri, for this clear explanation. Our next question is from Annette Bertolde from Latvian TV. Annette, please, you have the floor.
Hello. Yeah, you see me. So I'm from Annette from National Television, and we have 2 questions of interest. The first question is, how often do the vaccine manufacturers must report on the effectiveness of the vaccines to the EMA? And the second question is that currently in Latvia, it is data from August, 14% of people who were admitted in the hospital with severe COVID-19 were vaccinated, but 86% were not vaccinated. Would you say, is this a good proportion to say that the vaccines against COVID-19 provide a high degree of protection? Thank you.
Thanks very much, Annette. I think that also goes to Dr. Cavalieri. Dr. Cavalieri, please.
Yeah, so with respect to the effectiveness data, we have agreed with the manufacturer that they should report if there is an increase in vaccine failures in their monthly summary of safety. And also during the PSUR that have a 6-month cycle, they will have to explain all about the effectiveness studies that have been conducted. On top of this, there are studies that have been included as in the risk management plan that the marketing authorization holder is responsible for, and the precise timelines for that are also described in the risk management plan. In addition, let me say that whenever we see something emerging from data in the literature or from public health authorities that are of concern with respect to a potential reduction in the effectiveness, we will immediately discuss them with the sponsors, with the companies, in order to understand what is going on and what is the impact of such findings. With respect to your second question, I guess that very much depends on what is the vaccine coverage in the country, because that is the important variable to consider here. These figures, anyway, at first sight would look like that indeed the majority of those that get hospitalized with severe COVID, they have not been vaccinated, and I think per se is already a strong message that we need to increase the vaccination coverage across Europe and globally as soon as possible.
Thank you, Dr. Cavalieri. Our next question is from Naomi Kreske from Bloomberg. Naomi, please.
Hi, thanks for taking my question. Can you give us any update on the application from CureVac? How soon, if at all, do you anticipate getting a final data package from them this year? Thanks.
Thanks, Naomi. And again, that's a question for Dr. Cavalieri.
Yeah, so we have received already some clinical data that are quite important for us as a starting point to see where we are with this application. This data will be reviewed in the coming weeks, and we expect that by the end of the year, we will be in a better position to really understand what could be the next step for this vaccine, together with a full assessment of the other aspects of the dossier, including manufacturing.
Thank you, Dr. Cavalieri. The next question is from Donato Mancini from the Financial Times. Donato, you have the floor.
Hi, can you hear me?
Yes, we can hear you well.
Thanks so much for taking my question. So on vaccine equity and boosters, has there ever been a feeling among you that companies were trying to pressure you into approving boosters without there actually being an evident need to boost yet, with the exception, of course, of specific subgroups of vulnerable patients? Has there ever been a feeling that perhaps we're jumping the gun? And when do you expect to be able to make decisions on boosters? Thank you so much.
Thank you, Donato. That's a very important question. I think Dr. Cavalieri will start. Thank you.
Yeah, I think as normally we are in dialogue with the companies in order to understand what data are emerging and what we can conclude based on those data. As you know, we as regulators and other regulators in other parts of the world, we are starting in putting the question out of not rushing into giving booster if there is not a clear indication that they are needed. And we have been following rigorously this path. So now I think it's important for us always to base our decision on evidence and not on any pressure by any stakeholder, and that's what we will continue to do. Now, as said before, with the increase of breakthrough cases that we've seen over time, we do understand that member states in Europe and countries elsewhere want to consider already now the option of a booster, particularly in vulnerable groups. And that's why we have been expediting our review of the Comirnaty dossier, which is the only one that we have now in our hands as a complete package, in order to come up with an opinion on booster doses by the beginning of October.
Thanks, Dr. Cavalieri. The next question is from Gillian Deutsch from Politico. Gillian, please.
Hi, thanks so much. I'm actually going to follow up on Donato's question about booster shots. There are some countries already in the EU that are providing booster shots to their general population, not just immunocompromised people. I was curious what you would say to them. Are they jumping the gun? My second question is more technical about the application from Pfizer to change the emergency authorization or conditional marketing authorization for ages 5 through 11. I was wondering if they actually submitted that data yet, and I've heard some criticism that their clinical trials are too small. I was wondering if you could comment on that. Thank you.
Thanks, Gillian. Maybe we start with the second question first on Pfizer and the application. Marco, I think that is for you.
Yeah, we have not received yet the formal application for Pfizer. We heard that the company made some press releases and some statement around their top-line result of their clinical trials in this pediatric age, but we have not received that yet, and I think it will happen later on, probably in October. So we are in discussion with them to see by when this can be submitted.
Thank you, Dr. Cavalieri. And Julian, you had a follow-up question, or you had a first question on member state actions. I would like to give that question to Dr. Fergus Sweeney. Fergus, please.
So, thank you, and thanks, Julian. I think it's important to understand the roles and responsibilities as European Medicines Agency. We are evaluating the evidence both for the initial marketing authorizations and the specific dossier that Marco has spoken about on the boosters, but at the same time, the vaccination authorities in the member states, the national institutes, they have to take account of the broader domain of the different waves of disease, the different vaccines they have available, and how they want to protect the members of their public, and therefore they set out their vaccination strategy and make their choices, and can do that in that context. And we will evaluate the evidence and add to the marketing authorizations and product characteristics as we assess that to support the member states in making their decisions. But they can take a broader view and have the competence to do that.
Thank you, Dr. Sweeney. Now we have a question from Victoria English from Med News. Victoria, please.
Hello, and thank you for taking my question. The first question I have is really sort of fundamental. Do booster shots in all cases have to be the same active ingredient, in other words, the same structure, the same mode of action as the original vaccine?
Thank you, Victoria. That is a question for Dr. Cavalieri. Dr. Cavalieri, please.
Yeah, of course, when we evaluate dossiers, companies normally they try to focus on their own vaccine, and the data they primarily generate are around boosting their own vaccine. But as you rightly say, we have seen that in the vaccination campaigns, in order to increase flexibility, a lot of these heterologous approaches have already taken place in the context of the primary series, and we would expect that even more so could happen in the context of booster doses. And that's the reason why we will be keen to understand what kind of evidence could be generated also in this sense, to have a better picture around the possibility of using different boosters from what has been given as primary vaccination. So we are in dialogue with the companies, but also with the public health authorities and academic groups in order to really understand if we could gather sufficient evidence for informing the use of these vaccines.
Thank you very much, Dr. Cavalieri. Now we have a question from Gerardo D'Amico from Rai News. Gerardo, please.
Hello. Okay. The data of vaccination between 5 and 11 years presented by Pfizer with a press release report, immunogenicity and safety, but do not say if the presence of antibodies verified is immunizing. What data is expected EMI if Pfizer asks to wait for their vaccine to this age group? Thank you.
Thanks, Gerardo. And again, for Dr. Cavalieri.
I think indeed Pfizer in their press release a bit outlined what they expect will be the pivotal data that will be submitted to us. And again, as I mentioned before, there is an agreement at the level of the EMA with the Pediatric Committee for a pediatric investigation plan, which has been done also for the Pfizer vaccine. And essentially in this agreement was decided what should be the size of the study and the endpoint that should be considered. So overall, we have been agreeing that the concept of bridging immunogenicity to young adult, for which we have efficacy data and immunogenicity data, would be the way forward to allow an estimate of the level of protection of these vaccines also in pediatric groups. And this will be the basis for a potential approval. We know that there will be some additional data that will be coming up to support this, and this data will be collected as they come. But the primary application is expected to be on these clinical trials focused on safety and immunogenicity.
Thank you, Dr. Cavalieri. The next question is from Antje Sieb from Westdeutscher Rundfunk in Germany. Antje, please.
Hello, thank you for taking my question. There seem to have been cases of multi-system inflammatory syndrome after vaccination. Could you explain what is known about that?
Thank you very much, Antje. This question will go to Dr. Genov. Dr. Genov, please.
Thank you for the question. Indeed, we have informed that our safety committee has started review of cases of multi-organ inflammatory syndrome. Now, a bit of background. You might remember that in this new condition has been became known in the spring of 2020, and I think initially in the UK, where it was noted that in some children, and this is post-COVID, this is not post-vaccination, post-COVID, 4 to 6 weeks, there will be a hyperinflammatory condition that would cause this syndrome in children. Now, since then, there were reports also in adults, more rare, and it's a rare condition overall, and that is post-COVID. Now, what our committee is reviewing is we had a very limited number of cases, and it was triggered by one case, actually in Denmark, where a 17-year-old boy had possibly this multi-organ inflammatory syndrome, and no prior COVID was detected. So that is basically what has triggered the review. It's a complex evaluation. This syndrome is certainly related to COVID. If there is any relation to a vaccination, that's very unclear at this stage. But our safety committee is looking into this issue. Thank you.
Thank you, Dr. Genov, for this response. Now we have a question from Vasiliki Angouridi from News for Health in Greece. Vasiliki, the floor is yours.
Hello, hi, and thank you for taking my question. And, yeah, can you hear me now?
We can hear you. You're breaking on and off a bit, but we'll try our best.
I think it's a network. Okay, so there have been data suggesting that a second dosage of the Janssen vaccine may increase the effectiveness of the offset vaccine. Is EMA considering maybe recommending a second dose of the vaccine to member countries? Thank you.
Thank you very much, Vasiliki. That is a question for Dr. Cavalieri.
We are looking into this data, and indeed we are in discussion with the company to see by when they can be submitted to us, together with other data that are emerging with a second dose also administered with a longer interval. Just to remind everybody, this clinical trial essentially look into a second dose given after 2 months. And so we will be looking at all this data from this clinical trial and other studies that are ongoing in order to understand whether we can make a recommendation on a second dose of Janssen vaccine. But we have to wait for a good understanding of when a significant clinical data package can be assembled and submitted to us.
Thank you, Dr. Cavalieri, for this response. So we have now time for 2 more questions, and I know we have 2 follow-up questions. So the first follow-up question is from Donato Mancini from the Financial Times. Donato, please, the floor is yours.
Hi, I just wanted to follow up and ask you again, and this is a question for all members of the panel. Have you felt any pressure from companies to approve boosters? I just want you to address that specifically, if you can, please. Thank you.
Thanks, Donato. Dr. Sweeney will take this question.
I think it's very clear that we have to base all our decision-making and evaluation on the science and on the data that can be presented, whether it's by the companies or from other sources. We will maintain close evaluation of the data, and as Marco Cavalieri has described, we're looking carefully at data submitted, but we will make the decision based on the quality and definitiveness, if you like, of the scientific data and not on other considerations. Thank you.
Thank you, Dr. Sweeney. And now our final question, and I can see Victoria English from Med News has a follow-up question. So, Victoria, please, the floor is yours.
Yes, thank you. Back to the booster again, please. Would it be conceivable that a booster could act as a response to a new variant?
Thank you very much, Victoria. Dr. Cavalieri, please.
I think indeed the data that have been presented so far in the public domain would show that there is a really good immune response after the booster dose, which would confer such high titers of neutralizing antibodies that would be able to neutralize the main variants that are around now, including the Delta. Now, our assessment is still ongoing, so I cannot tell you where we will end, but the preliminary data would be rather reassuring in this sense.
Thank you very much to everybody for your really excellent question this afternoon and for attending our press briefing. Thank you very much to our panel for taking part. As always, if you do have any further questions that have not been answered here, please do not hesitate to contact the EMA press office. Thanks again and goodbye.